struggling to get so good. For the last almost 1 month, I'm trying to get the Vice Chancellor's appointment. With personal mail लिहिला he doesn't answer. Official mail लिहिला he doesn't answer. तिथे बॉम्बे ऑफिस आहे NUHS सेंट जॉर्ज तिथे संजय देशमुख म्हणून राहायची. मला म्हटलं तिथे कधी येतात तर मला अपॉइंटमेंट दरवेळेस सांगतात की आता कॉन्ट्रॅक्टर त्या दिवशी येणार आहे यू बी इन टच विथ अस. म्हणतात ते असं वेळ नाही म्हणजे IITने जायचं बॉम्बे जायचं मिनिस्टरने बोलायचं आम्हाला लोक आणि म्हटलं की तुम्ही नाशिकला अपॉइंटमेंट द्या वेलकम टू नाशिक ते त्याचं उत्तरच होतं. आणि आता असं म्हणतात की जामकरजीला राहतील तर नाही केली तर आपण मिनिस्ट्री बनवली काँग्रेस मिनिस्ट्री आता हे लोक काढतात
Dinesh. Good evening friends, and we welcome you for the first PG Clinic webcast for 2015. This has been brought to you under the Presidential Action Plan 2014, and the good news is that it's going to continue for 2015 thanks to the efforts of Dr. Vijay Yevle and Dr. Sachidanand Kamath, who is our President for 2015. This program is brought to you through an academic grant from Alembic, and we are really grateful to them. Those of you who have missed episodes in the past can watch the same on the same page on the link that has been sent to you. These episodes can be also downloaded if you have the appropriate software. An announcement before we start the clinic is that the IAP Mumbai is, as every year, starting the PG clinics for theory from the 17th of January, and the last date for registering for that is the 12th of January. So those of you who are interested should go to the IAP office at Sion and register for that. Or you can contact Dr. Sushant Mane, who is the Secretary of IAP Mumbai, for this. The next broadcast will be on Wednesday, the 14th, Rajesh? 14th of Feb from Chennai at 2:30 p.m. So, should we start? Come.
A very good evening. My patient, a 4-year-old male child, Saino, resident of Shivaji Nagar, hailing from Banaras, Uttar Pradesh, Muslim by religion, Sheikh by community, informant being father, came with the chief complaint at the time of admission as fever since 4 days, joint pain since 4 days. The fever was moderate to high grade, not accompanied with any chills or rigors, intermittent, responding temporarily to medications, not accompanied with any rash, with the child being active and well during the interfebrile period. The joint pains mainly in the knee, also in the ankle, wrist and elbows, bilateral, symmetrical, dull aching, which is concurrent with the fever without any swelling, no spread or radiation to other part, no temporal predilation or diurnal variation, without any restriction of movement, without any morning stiffness, redness over the joint or any history of back pain. Joint pain is aggravated mainly during the fever episodes and get relieved on giving medications. The pain is severe enough for the child to ask parent to massage the part. The child does cry with pain, but the night sleep is not disturbed by the pain. The child was admitted with the above complaints to our hospital 10 days back with a history of 4-day fever and joint pain. At this point, I would also like to add a significant past history of hospital admission for similar complaint, and the history of complaints during that admission was also similar, as the patient was apparently alright at home for only 1 day after developing the same complaints. So the child was absolutely alright for 1.5 months back when he had the same symptoms as above of fever and joint pain for a period of 20 days, and a history also of bleeding per rectum for a period of 3 to 4 days, following which he came and was admitted in the hospital, and the bleeding was severe enough for the child to receive a PRC transfusion, and the child was given some IV medications and was discharged. Following the discharge, the patient was alright for 1 day, and then a history of 4 days of similar complaint and the second admission. But during this second admission, the patient does not have any history of bleeding per rectum. There is no history of any loss of weight, no history of any abdominal distension. There is history of loss of appetite over the time period since the start of fever, that is about 1.5 months back. There is no history of nausea, vomiting, bleed from any other site apart from the bleeding per rectum at that time. There is no history of any joint swelling. There is no history of jaundice in the patient or in any other family member. There is no history of blood transfusion in the past in the patient or in the family members. There is no history of swelling at any other site like inguinal, axillary or the neck region. There is no history of any similar complaint in any other sibling. There is no history of any eye pain, redness or any urinary complaints in the patients or any history of oral ulceration. There is no history of sore throat, chronic abdominal pain or chronic diarrhea. And there is no history of COX or COX contact. Birth history. The child is born of third degree consanguineous marriage, normal vaginal delivery, hospital delivery. Birth weight was 2.5 kilograms. The baby cried immediately after birth without any NICU stay. The immunization history, the immunization is complete till date. Family history. Father is 32-year-old laborer, earns 9,000 rupees per month. Mother is 30-year-old illiterate housewife. They have 4 children, the eldest being 7 years, then 5 years, 4 years and 2 years. The present child is the one with 4 years of age. There is no history of PRC transfusion in sibling or other family members. Dietary history is suggestive of a calorie deficit of 500 kilocalorie and 5 grams of protein. Socioeconomic history, the child, the family is falling under upper-lower socioeconomic strata, living in a kacha house with 6 persons, with 1 door, no windows, with a common toilet facility. Developmental wise, the developmental history is normal as per age.
Yeah, so who would like to start analyzing the history? Or you wanted to ask any more questions? Do you have enough information? Anybody? So what we understood is that about Amrit, I'm asking you. What we understood is that about 1.5 months back, this child started running fever with joint pains. Now, how long did that fever last?
It lasted for a period of 20 days. He was shown in private in between and then referred to another hospital from where he came to our hospital. The fever and joint pain were for 20 days with the last 5 days also having bleeding per rectum.
That bit we got. What I want to know is how did the fever behave in those 20 days?
The fever was mild to moderate grade. This time the fever is moderate to high grade. That was mild to moderate grade, intermittent, responding to medications, and when the fever was present there was joint pain.
Okay. Any thoughts? I think to start off with you could probably split the symptoms and you could first talk of fever alone, then you can try and correlate the joint pains, then talk of the bleeding separately, then try and see if we can correlate everything. So, talk of fever first. Come on, just a general discussion of what this fever could be. You want to try?
Fever of infective etiology. Running for 20 days, we would think of viral infections or bacterial infection or tuberculosis.
Okay, so if you are thinking of fever of infective etiology, how will you try and separate out between viral infections, bacterial infections and say tuberculosis clinically? So for and against points that weigh in favor of one over the other. How will you try and separate them out? Those who want to speak, please raise your hand. Mic will be brought to you.
Fever of bacterial etiology, in that case, symptoms would have localized by this time.
Very good. So, if it's a 20-day fever, you expect it to localize. What else?
and as per history says, the child was normal, apparently normal in between the interfebrile period.
So that's again a small point against a bacterial infection, that this, if it's a bacterial infection, it hasn't localized for 20 days. If it hasn't localized and if it's yet a bacterial infection, the child should get progressively sicker. We would have some bacterial infections that may be hidden even at 20 days, but then the child would be sicker.
Well, it did localize in the intestines. There is a bleeding per rectum. What makes you say that's not localization? You wanted it to localize, right? Yes, get another symptom. And it has localized. Why do you say it's not localized? Any thoughts on that?
We also have joint pain in this child.
We'll come to joint pain, but first answer. So I'll take that. First answer sir's question, that is this bleeding, can you call this bleeding from the rectum a localization of the fever?
Of course, dysentery comes like that. It's a bacterial infection. And you haven't asked whether he was partially treated already. If he is partially treated, he is not going to show you localization. It will come much delayed. So what makes you say that this is not a bacterial infection?
Come on, some more thoughts
Some thoughts on that. Come on, learn to talk. Learn to talk.
Bacterial infection, child will be more sicker. As in between the child is fine. That goes against.
Any other points? That's one point. Any other points?
Sir, if there is a bacterial infection could have spread to other part of body, so child become more sicker and more toxic, and presenting different complaints apart from joint pain, and affecting different organ of the body.
So what you are trying to say is that if a bacterial infection has been treated and not responded, then it might complicate. So you could get some symptoms of complications. Okay, what else? Any other thoughts? Mike.
Dysentery will not present plainly like as a bleeding per rectum. Associated symptom like pain in abdomen or other symptoms like sticky motions and should be associated, will be there. And plus in dysentery there would be not such blood loss will require blood transfusion, as child had required blood transfusion for the bleeding per rectum post episode.
I think what we are driving it at is your history is so much incomplete. If we are not able to judge what it is, it's only that the history is still lacking more details. You haven't asked many details of fever. How did it start? How did it progress? Did it respond to paracetamol? What else was given? So many important things. If you don't learn to ask these questions, you will never know what the problem is. Same way about each symptom. Origin, duration, progress must be in details asked. If you don't ask that, you will never know what this is. This could be any kind of fever. It could be a non-infective fever. It could be inflammatory fever. It could be a malignancy fever. It could be drug fever. It could be, name any fever. How can you not know details? And unless you know that, you will never catch all that. And I think that's very important. Nobody has asked you what has been the progress of fever. 20 days of fever. Is it getting better? Is it getting worse? Is it same? What has happened? Is that not important? Learn to ask all these details, then only you will know what this fever is. Otherwise you will never know that. So, do you have any more details like that?
So the fever is similar, it is not progressed, as such the child has not gotten sick, but during the last 4 to 5 days he has had episodes of loose stools along with bleeding PR. That is the only thing that is in addition to the fever of 15 days, the last 5 days have also associated with loose stools and bleeding per rectum.
Always learn to ask 5 questions to every fever. 1. What was the fever like on the first beginning of the illness? Was it low fever? Was it high fever? What was it like? What was the onset like? Next is that what has been the response to paracetamol? Does it come down quickly or it just does not budge at all? Third thing is that, is it rhythmic? Every 4-6 hours my child gets fever, I give paracetamol, he looks a little better, he gets worse again. Or is it totally non-rhythmic? Is it totally erratic? Then you want to know whether, how is he when the fever comes down a little? One of them said that, he was looking better, so it may not be a bacterial infection. Yes. And then lastly, if that is so, then what has happened because of this fever? Has he got sicker? Is he playful? Is he active? Or he looking fine in spite of 20 days of fever? All those are important questions. And unless we know that, we will not know simply on the history what this fever means. It could mean anything. So learn to ask those questions, right? And therefore, with limited knowledge now we know, we could guess that this is unlikely a bacterial infection. This is unlikely a viral infection.
Why? Can it not be a viral infection? One second.
The duration is too long for it to be a viral illness. Unless it's a chronic viral illness like HIV or...
Name chronic viral infections. Name viral infections where fever goes on for 4 weeks.
HIV maybe.
Hepatitis B.
EB maybe. Epstein-Barr maybe. So it could still be a viral. Agreed? Your statement is right. Majority of viral infections don't go that far. But I give you an example. You said some. So you need to again further say what it could be.
Sir, in chronic viral fevers, the child will not be absolutely all right in between the fever episodes.
Fine. So that's the reason why it cannot be. Okay. Why not an EB virus? Why not a CMV? So you must have some reasons to say why not. Okay. Give a thought, you will know.
Other than fever, there may be other signs.
What other signs?
Swellings, which he mentioned weren't
Very
present.
good. So when there is no other involvement, probably not. You wanted to say something, just pass on the mic because they are recording.
So the same thing I was saying, that the duration is contradicting the viral infection, and same like for CMV, he might have come with jaundice or something, and he's apart from the joint pain and the bleeding, he doesn't have any complaint, no vomiting, nausea, anything.
What about chikungunya? What about dengue?
Sir, he
Breakbone fever, no dengue?
But sir, no pain in abdomen, no vomiting, and the duration, and it is like the fever, there is a course of dengue, and it is not simulating a dengue fever in which there is a recovery phase and...
What about chikungunya?
Joint pains and fever, yeah.
Joint pain may last for more number of days. Fever may not last. Fever may last for 1 week or so, and joint pain may be debilitating and last for more than the fever. It was always associated, the joint pain was always associated with fever.
Okay. So...
And joint pain will be very severe to restrict the movement of the child.
Okay.
Can it be TB?
Multiple joint
20 days of fever.
Multiple joint involvement goes against tuberculosis. Single joint involvement is more common in tuberculosis.
What about leukemia? Fever and joint pains. Short illness, 20 days. Very much possible, no? Acute leukemia. So everyone agrees this could be acute leukemia, then he bled also.
Child is looking like, as per history, is not sick looking. Interfebrile period is also child is well. So less likely leukemia.
Okay, so if that history is reliable, then that is a strong point. Any other points?
No organomegaly.
That we don't know yet. We have not examined the child.
There is an associated symptom like weight loss and fatigue and weakness. Or
see, for weight loss there is no enough time, I suppose. Means it's difficult to say. There is loss of appetite. That we have a history of loss of appetite.
Leukemia is very low grade fever. I mean, there is not first complaint like as a fever. First complaint is like weakness or weight loss or decreased appetite or swelling.
Okay. So what he is trying to say is that the RBC component is not evident from this history, at least, as in no progressive pallor or no weakness or all those things have not been noticed. So at least from that point of view it is not evident. What else? Can it be, so we are not talking of joint TB, but can it be TB as such?
Rajesh?
Yeah.
Is this mic okay? Yeah, so there was this question raised by somebody that why can't it be dengue because of joint pain, bleeding. But the point is that one is the duration which is against it, and secondly, this child would have been catastrophically ill if he was bleeding. He would have probably been in DIC. And that is not the case, and therefore we are not thinking of dengue.
Absolutely.
When you come to non-infective fevers, there are some queries, so I'll get those later. You want me to ask now? So why can't it be Henoch-Schönlein purpura, somebody said. So that's one of the thoughts that has come.
Okay. So where were we? Okay. Or anyone wants to take that up? Why can't it be Henoch-Schönlein purpura?
In HSP, sir, in HSP there will be abdominal pain and there will be a rash. Palpable purpura will be there. There is no issue such.
And fever will not persist for 20 days.
In HSP, fever will not persist for 20 days. We'll have the onset of fever followed by all this manifestation.
And what is the cause of bleeding PR in HSP? That is the crux. I thought you said interception. Because you said it without the mic, that's why I'm just repeating. Is that right?
Yes, sir. Yes, sir.
Okay. So any other non-infective causes that we are thinking of, because we are not, from whatever history we are not comfortable with a bacterial infection, we are not comfortable with a viral infection. So tuberculosis, joint tuberculosis is out. So are we thinking of non-infective causes?
Connective tissue disease.
Sir, can it be HUS, hemolytic uremic syndrome?
So you tell us, what are your concepts of HUS and does it fit into that?
So bleeding.
So first let's discuss in short a classic HUS, how will it come? Classic HUS, and then we'll see whether we can fit this in.
As far as I know, fever and bleeding per rectum is fever and bleeding per rectum are
a very acute history, a 3-day history of a prodromal diarrhea followed by with fever and renal complaints. That will be
in HUS you have D plus D minus HUS.
Yeah.
So in D plus we'll have history of diarrhea, then followed by history of sudden onset of pallor, oliguria, and renal failure symptoms.
Yeah. So all those other symptoms, and basically HUS is a very acute, short-lasting history. This is spanning over 20 days where besides fever and joint pain he is playing. And at the fag end of 15-17 days he had one big bleed per rectum. See, that one big bleed per rectum is also to be analyzed. It's not just bleeding PR. You have to talk of it as one big bleed per rectum. So what do you make out of that one big bleed per rectum?
So 4 to 5 days of loose motions with bleed, PR, frank blood.
Oh, I thought you said okay. Sorry.
So 4-5 days continuous of bleeding PR with loose motions.
Okay. So but then loose motions as in loose motions with mucus, with blood?
Without mucus, only with blood.
Okay. So what do you make of that? Anybody?
Sir, could it be leptospirosis?
Leptospirosis. Why?
Because of fever and joint pain, and also GI manifestation in leptospirosis. Though nausea, vomiting, abdominal pain are predominant, but also bleeding is rarely, but is a manifestation of leptospirosis. But there is no history of contact with animals or.
So see, more important, of course, that history of
Jaundice will be there by 20 days.
Okay.
So why not an HLA B27 associated fever, joint pain and bleeding PR? So in an inflammatory and any autoimmune disorder could explain it.
Okay, very good. Yeah, so we'll finish this leptospirosis. So see, like just now how Anand said about dengue, whenever you think of a infection which can have bleeding as a complication, whether it's dengue, whether it's leptospirosis, you must remember that that bleeding comes as a complication in for what reason? So that complication is DIC or a bleeding diathesis or what. So for that infection to reach that stage, whether the child's picture is looking like that, that is very important. So you can't have a walking, talking, playing leptospirosis and suddenly he starts bleeding from the rectum, because you know that DIC exists in leptospirosis, So that's not the way. So therefore that's quite unlikely. What about this suggestion? Yeah.
Connective tissue disorders like SLE could present with fever, joint pain, with bleeding manifestations, but the age is slightly not going, but it could be any connective tissue disorder.
Yeah. So I think there's a good suggestion from both of them that we must consider non-infective causes like some connective tissue disorders which could give rise to fever and joint pains. However, there are some points against that as well, but we'll keep that in mind. Sir, I think.
One important thing is this particular had joint pains only when there was fever. And when there was no fever, there were no joint pains, this child was moving about. So there was only arthralgia when there was fever, this child has no arthritis. So you are talking about, all those connective tissue disorders, including somebody suggested Ritter syndrome and everything, you had that in mind. If he has these manifestations, there will be joint pathology which is persistent whether there is fever or no. It may be one joint, multiple joint, it will not disappear. So he didn't have arthritis if this pain disappeared, nor was there any swelling there. No. So he had fever related arthralgia involving all the joints, but no arthritis. So none of these things would come up also. Connective tissue, inflammatory bowel disorder like ulcerative colitis can present as bleeding PR, and it can also have joint manifestations. Though such a prolonged fever is not so common in ulcerative colitis, often there is a lot of pain in ulcerative colitis when they have such severe bleeding coming up on day 4, day 5. So while you consider abdominal pain with arthralgia or bleeding PR with arthralgia as inflammatory bowel disease, it really doesn't fit in here. So this bleeding PR remains relatively difficult, either a local cause or a general cause. But none of them are so very easy to explain this.
Sir, taking it from where you brought it out, if this bleeding PR is without any pain, then it almost suggests that either there is a vascular malformation or some vascular cause of bleeding. For example, somebody who would have hemorrhoids would also bleed, maybe without pain. And therefore now we always ask this question, was this child absolutely alright 1.5 months back? Was he a absolutely healthy child?
Sir, absolutely healthy apart from the fact that he is anthropometrically malnourished.
So history-wise
he is absolutely fine, no hospital admissions in the past.
Normally would consider bleeding PR as painless bleeding and painful bleeding. Now this is painless bleeding, so suggests more a local cause, but even then, bleeding like polyp can bleed like that, but they don't bleed so much that it would require a blood transfusion. An ulcerative colitis or enterocolitis can present like that, but the child is very sick and there has to be some cause for enterocolitis in this particular child. So it becomes difficult to explain such severe bleeding PR de novo in this child.
Was the bleeding PR fresh blood or melena?
It was not melena. It was
hematochezia.
Yeah, because otherwise he could have a bleeding in the stomach and then it can present as melena, though it will not be recognized by parents. The parents will not recognize that black colored stool is actually bleeding. Black colored stool, and doctor will interpret it as melena. They have brought it as bleeding, but it was a correct question.
Rajesh, one request. Can you tell us what our thoughts finally in summary are about the fever? What are we thinking of? What are the causes?
I think this fever is certainly not one of infection as we discussed. So we must look at this fever as non-infective fever. Non-infective fevers are largely two types. One is an inflammatory disorders that we are discussing, and another is a malignancy, leukemias, etc. So we need to start looking at one of these two. Talking about the bleeding, I think it's important that she brought out a question, what's the kind of blood she is passing. But if the bleeding is very severe, coming from above, even then there could be still what looks like a fresh blood because the transit is very fast. But there are also clots coming out. So we need to ask more details. There could be a child who is passing fresh blood followed by the clots as well. If that is so, it's coming way up. It's not from the rectum or low down. So we need to look at that very carefully. If you look at a child who has fever and a bleeding, I would almost feel that there would be some element of discomfort or a pain. If we take away fever, then we can discuss whether it's a painless bleeding. But which is this bleeding which has also fever? If you combine the two, it better be some pain or discomfort. And the point again that we are learning is, we need to ask all these questions up front. The parents are worried about bleeding, they are not much worried about a little pain that he has. And therefore they don't come out with pain. Have we asked them, is there a pain, is there a discomfort? Then only this can come out. But if you consider fever and bleeding together, let it be an inflammatory pain. Otherwise you will have to separate the two totally. And why should two diseases come together all in the same sequence? So I would still feel that it's going to be one of the inflammatory or malignancy that we are talking about. We'll have to look at now both. Now as he pointed out that this is not an arthritis at all. This is just an arthralgia. Now arthralgia is a manifestation of also connective tissue disorder, not necessarily an arthritis. To that extent, it is unlikely a feature of a leukemia, because leukemia doesn't come out of that. Leukemia may present what looks like a joint pathology, but it could be a bony pain, but still the pain doesn't have relation to fever. And therefore it is neither a bony pain nor a joint pain of a leukemia or any other hematological disorder. So this is likely to be one inflammatory disorder. What else could it be? Could it be this kind of fever which we have not understood what the main cause is, but could it be a complication of that fever or that cause of fever? We did talk about the dengue and complication. We talked about leptospira and complication. Any non-infective disorder also could have an immune complication. Like say an hemophagocytosis is an immune-mediated complication. The child could have bleeding, child could have continuation of fever. So all that we understand in this child is that this child has got an immune-mediated disorder. Is it an autoimmune, like we are discussing the inflammatory bowel, etc.? Or is it an infection-induced immune, which we have no clear-cut history of any infection to blame, so that's less likely? Or is it totally an immunoimbalanced disorder, which is called malignancy or leukemia? So we'll have to work out that. If you look at the leukemia, then leukemia is unlikely to present just as a bleeding per intestine. It rarely comes for that. To that extent, it is less likely. So we will move out of leukemia on the history. We have moved out of probably an infection-induced immune disorder, because we have no way to call which infection it started with, and therefore we might stay even now as an autoimmune disorder. Okay, let's call it an inflammatory bowel for that simple understanding. Point that he made was right, that it's an inflammatory bowel is just having no pain but bleeding, but to which, as I said, that we will have to be very sure how much is the pain. See, the main complaint is bleeding, so the other complaints are often not coming forth, because what bothers them most is the one that is reported, and many times we might miss on that. Again, if you look at an inflammatory bowel disease, then again, like every immune disorder, there is a wide spectrum. But what is more important in this child is that the same thing seems to be recurring again. He has had some illness, he has not recurred this time with a bleeding, but he has recurred with fever and recurred with some pain, and it is only 4 or 5 days. Earlier it took a long period before the bleeding started. This time we have a short story. But what is more important is, he is having another repeat illness within a short time. What repeats? Again, an immune-mediated disorder repeats. Infections rarely repeats. Leukemia doesn't repeat like that. So again, I will fall back on saying that this must be an inflammatory disease. Okay, unlikely infection-induced, so must be an autoimmune. So we'll call it as an inflammatory bowel disease as a prototype. And I think at this point of time, probably that's the best bet to go by. What we have learnt out of this discussion is that the history needs to be much more sought out in depth and details. And how did you ask all these questions? You start looking into your mind and say, what this fever could be? Could it be an infection? Let me ask questions to say whether it could be a bacterial, viral, fungal, tubercle, parasitic, etc. Then could it be non-infective? What question would I ask him about fever? So I think when he starts, so medicine is thought in action. You think and act at the same time. So you're thinking and also acting. Most of the other profession can think, analyze, collect data and then plan their management. Okay, medicine is thought in action. On one hand you think and on the other hand you act. So I think, could it be a bacterial infection? I ask a question. Again an action. So we will learn that our history should come out with answers to a probable question that we have already started looking in the mind. In this question, in this child, therefore, all kinds of infection, all kinds of inflammatory disorders, all kinds of malignancy disorders, I wanted to ask that. And I think in summary I would say that whatever history we got, I would pitch in the best possible bet would be it's an inflammatory disorder. I think that would be the best way. Repeat illness makes me strong to say it must be an inflammatory disorder. And I think that's the best way to go.
So just to consider other causes of long fever, long duration fever of 20 days without localization is tuberculosis. Low grade, going on like that. I mean, nothing is against it. Any fever which is longer than tuberculosis must be considered. Joint pains in the tuberculosis, we are not talking about a joint disease. Another thing to be mentioned is systemic arthritis. Because when there is a long fever and joint involvement, you think of connective tissue illness. Systemic arthritis can occur at any time. It can have joint manifestations which may be transient. The fever is often there, high fever going on twice a day. Sometimes the rash that is there, the evanescent rash can be missed. The child looks very sick when there is fever. When there is no fever, the child looks relatively normal. So in long fevers, this is to be considered. And just to mention malaria as a cause of fever for any long fever, whether it is a spiking fever, irregular fever, erratic fever, just to complete the list, though none of them can really explain the bleeding PR.
Can it be rickettsial infections or relapsing fever, low-grade fever, long-time fever, joint pains? Bacterial can still...
Yeah. So see, rickettsial infection, yes, I mean, you would theoretically consider, but again, rickettsial infections don't drag for 15-20 days, and in say 4-5 days, 7 days, they will peak and the child will become sick, will develop a rash, will develop headache, and will be very irritable child, and then there will be complications. And then that bleeding cannot be explained. So again, rickettsia we think of primarily, means whatever model we see is of a short duration, not of a 20-day duration. And what else did you say? Relapsing fever like brucellosis or Borrelia or all. I think we have no experience of that, but in general, relapsing fever means there has to be a good 5, 10, 15 days break in between and then again a fever. That is what we will call as a relapsing fever. So this duration in between was too short. Okay. And relapsing fevers are usually just fevers and pretty much no other symptoms. Whereas here you've got fever and joint pain from day one, all along joint pain and then this bleeding. So that's less likely.
Rajesh, 2 questions here. One was a thought that Campylobacter dysentery can cause reactive arthralgia. The point is the arthralgia preceded the dysentery, so that's out. And they are usually subsequent to the diarrheal
so the
episode.
time sequence is
it doesn't fit
haywire.
in. The other thought process was that could this PR bleeding be secondary to a drug reaction? Well, mucosal bleeds, which are, they're usually catastrophic because of platelets being dropped. And what is your take on that? What would you say?
No, I think drug reactions causing a bleeding PR is pretty unlikely. Means a drug reaction can either cause inflammation, local inflammation. So there will be a little ooze from wherever it causes a inflammation, or if it causes a hematological reaction, then it will be secondary to low platelets, like you said. So there will be many other manifestations.
I think the correlation was taken from hematuria, which we get secondary to NSAIDs.
Yeah.
So that's the thought process.
Yeah. So I think we'll examine the child.
What do you expect on examination? Let's put it before we examine the child.
Pallor. And maybe we should see the joints also, that if there is any swelling or redness.
First tell me general examination. What must be his weight, height?
4 kg, 4 years. 4 years.
4 year old. What must be his weight and you
Um,
want to justify.
11 kg.
What grounds you said some number?
11 kg. Because he said that anthropometrically he is malnourished. So he
Don't go by what he said. He leaked the information. Sir is asking.
Look at him and tell me what must be.
Sir is asking that your analysis of history, what picture it creates in your mind, what do you expect?
For example, he said he was absolutely alright 1.5 months ago. So I expect how much can he go down in weight? Okay. Imagine what must have been his weight 1.5 months ago. He is a normal 4-year-old.
So 16 kg. 15 to 16 kg.
So 16 kg. How much can he lose in this 20 days of fever in between alright and last 4 days? So maybe 2 kilos less.
2 to 3 kg.
Okay. If he is much low, then we are missing something on the history. His history should tell me that he must be 14 kilos. If he shows me something less, then why did we not make out in the history that he is less? That's what we need to learn.
Nutritional.
How much must be his height? Is he going to lose height in 1.5 months? No. So what is a 4 years old height? 100 centimeters. So we want him 100 centimeters and 14 kilos. If you give me less, then I'll ask you, why did we not pick it up? Okay.
Yes, sir.
Would he look very pale?
Not very pale.
No, he has been transfused also,
Transferred.
I suppose. What
But-
general examination you expect?
Sir, first of all, I'll see all the signs of malnourishment if he's having.
Yes. So now,
Right
but
from
we
the
are not
head.
expecting malnutrition in this child, based on our history.
Sir, I'll look for pallor, then degree of pallor, and then
So
if
tell
there
me
is
what
some-
you expect. I will do a full general examination. Do I expect lymph nodes?
Yes.
Why?
No, but I will, because both infectious may, or if it is
No,
infectious,
now we have discussed the history and probabilities.
Okay.
Based on that, do you expect lymph nodes?
sir, I'll consider tuberculosis as one of the DD, and for that I'll look for the lymph nodes.
All right.
And even if it is inflammatory or if it is connective tissue, then also I'll look for the lymph nodes.
Fine. She is taking her help. She said connective tissue disorders also may have lymph node, and a leukemia also may have lymph node. So she is not surprised if there are lymph node. Fine. And do you expect any bleeding on the skin?
Not now.
There is a bleeding disorder. Okay. If I pick up a bleeding on the skin, then I have a leukemia there. So do you expect that? Probably we said no. So we don't expect the skin anything. And nothing else on general examination. Right? Do you expect anything on abdomen?
On general examination,
No, general examination is over.
Systemic?
Lymph nodes may be, pallor may be, and some
spleen, I'll
malnutrition.
look.
Abdomen?
Spleen and liver.
You
and
expect? Yeah, please. Rash. Yes. Okay. Spleen and liver you expect? Why?
Hepatosplenomegaly can be a part of a connective tissue.
Yes, and so also part of the rest of the thing. So you expect liver and spleen. Alright. Ascites? Why not?
Because portal hypertension isn't the
liver is involved, no? You said liver is involved. So why not ascites?
It's not a chronic, we are not suspecting a chronic liver disease.
It's 1.5 months. Okay, it's chronic.
Serositis in the form of pleural effusion, pericardial effusion.
Expect ascites?
No.
Why?
Multiple serositis in the form of pleural effusion, pericardial effusion may be there in this.
Alright, but the history didn't suggest that. Okay, so we don't expect ascites. Ascites would be a liver cell failure. Okay, this one is obviously not. So no ascites. Okay, only liver and spleen. Maybe you look for lymph nodes there if any by chance. Respiratory, cardiac, CNS. Normal. Now let's examine and see. We should not get anything totally a surprise. Okay, otherwise where are we discussing? Okay, come. Now two volunteers to come and examine. Come, any two volunteers come up. Come on, anything. Now it's so simple. You know what you are looking for. Come. And let somebody else come with her also. Come. So that give her a company. Come, who wants to come? Come.
You're looking very tense. Are we going to be surprised?
No, sir. I have mentioned in the history about dietary history being deficient in calories and proteins both.
How deficient?
500 kilocalorie and 5 grams of protein.
And he was so absolutely well also 1.5 months ago.
I mentioned that apart from the nutritional deficiency.
So what I mean is that, see, we all learn when we teach. Okay. We want to sharpen our thinking process history. That's the thing. First only on inspection. Okay. Without touching, you go on talking. Come, hold the mic. Just on inspection, keep on talking what you see.
Child is playful. He's not sick looking. He's stunted for a 4-year-old.
You will make him sit here? Huh.
So he's a playful, not sick child who looks stunted for a 4-year-old. Weight also is less for a 4-year-old. He's obviously pale.
There's no icterus and frontal bossing is there, and the height is saying that he's chronically malnourished, and skin is dry.
So once you say that, he's looking chronically malnourished, since you mentioned that, say some important findings related to that on inspection, either positive or negative, since you have said that.
Dry skin, koilonychia is present. His hair color is also depigmented, hypopigmented.
Rajesh, on general examination somebody said we should look for clubbing if we are thinking of IBD. I think that's a good point.
There is no clubbing, sir.
Yeah, but we should look for it.
Yeah.
There is no clubbing.
I can't see any obvious joint swelling or the child doesn't appear to be in pain.
So what I meant is, see, when you mentioned that he looks chronically malnourished, then maybe on inspection you try and decide whether it's calorie malnutrition or protein malnutrition. So you talk of wasting, whether his cheeks are sunken, whether he has loss of subcutaneous fat, whether he has edema feet. You said that his hair is discolored or depigmented. So then does he have edema feet? Does he have apathy, other signs of protein deficiency. So means learn to correlate all this and say as much as you can observe on inspection.
There doesn't appear to be any edema feet, or the buccal fat isn't reduced.
Yeah, so let's get the anthropometry and let's try and analyze that.
The anthropometry wise, the observed weight is 11.1 kg, which falls just below the minus third standard deviation. The height is 89 centimeters, which is again just below the minus third standard deviation. And the weight for height is between minus 2 and minus 1 standard deviation.
So what do you make out of this anthropometry?
So definitely he's stunted, and what was the weight for?
Weight for height is between minus 1 and minus 2 standard deviations. See, let me, whenever you analyze anthropometry, when he tells you once or you've taken the height and the weight, go to this concept of putting the height age and the weight age, which is the same as weight for height. So 11 kg is what age?
1 year old.
Not 1. 1 is...
1.5.
So 1.5 to 2. And 89 centimeters is what age? 2 years. So when both are close to each other, this is the way to analyze height and weight quickly in your mind. All that weight for height, percentile, minus 1, minus 2 tends to confuse you. But moment you get 11 kg and 89 centimeters, it should ring a bell, both look similar. So weight and height look almost of the same age. So now what is and that's fitting in, because weight for height is minus 1 to minus 2. It's not outside minus 2. So it's not abnormal. Minus 2 to 2 standard deviations is the normal range. So weight for height is normal, right? And when you talk of chronic malnutrition, you take weight for height into consideration, not weight for age, right? So now what does this tell you? That weight and height are equally affected. What does it tell you?
It's a chronic malnutrition. There is no acute on chronic.
Okay, so let's revise this concept. So whenever there is chronic malnutrition, let's say there was one point in time when this baby or this child was not malnourished, whatever point in time, be it on day 1 of life, be it antenatal, whenever. When the baby starts getting malnourished, what will first get affected? For how long? For a few months before the height starts getting affected. So in that race, the weight will always be worse affected than height. You get what I'm saying? So what I'm trying to say is that chronic malnutrition, the pattern should be weight more affected than height, both affected. So when you don't get this pattern, question yourself, is this chronic malnutrition? Of course, there's a stage called adapted malnutrition where after many years both would look nearly similar, but train yourself to pick up a state where there may not be malnutrition and both seem to be proportionate to each other. Okay?
What you say is absolutely correct, and even minus 1 to minus 2 standard deviation is not severely managed, but it is undernutrition. So as he said, height is affected, weight is but weight is little more affected for that height. And if suppose weight and height are absolutely proportionate to each other, then
maybe familial short stature.
Yeah, then you think of a familial short stature or endocrinal disorder, non-malnourished. So this particular child and that child will be only stunted and not malnourished.
Can be acute on chronic malnutrition?
There is no question of acute. This particular child's weight and height are proportionate. So there is no question of malnutrition. So a short child, say hypothyroid, or a child who is a familial short stature or something is basically short but not undernourished. This particular child is short, and even for that short height, his weight is slightly less as suggested by weight for height. So maybe he's little. So you're not going to get, you were looking at, say when you talk of malnutrition, you only think of extremes of malnutrition, marasmus and kwashiorkor. But most of the malnutrition is in between. So you may not get hair signs and edema and all, but you may find them that he's slightly undernourished. Arm circumference may be little less, subcutaneous fat may not be very obvious. So you are not going to get frank signs of nutrition. Those extremes are uncommon.
Actually, if this child's height age is 2 years and the weight age was say 1.5, then you would have said, yes, he has definitely a malnutrition. But if his weight age was 6 months and the height age is 2 years, then very likely it's an acute on chronic. You are asking acute on chronic. Other thing is that when you give an examiner to say is a chronically malnourished, you must demonstrate me signs of loss of subcutaneous fat, muscle mass, behavior, all that. Most of these children who have weight for height nearly normal do not have any signs of malnutrition like subcutaneous fat. For example, he has reasonable fat here. You should look at his axilla, his thighs, and you will find very minimal. Surely, as Dr. Khare said, he has probably a grade 1 malnutrition. We don't deny that, but it's not a chronic or a severe malnutrition. That is important. Another is the behavior of the child. You did say that his hair. Now you made a correct observation. What is that due to? It's very common that when a child does not have any signs of protein malnutrition and no other corroborative signs, like his behavior is not like a protein malnutrition, he is no edema at all, his hair is like this, always ask the parent, they would say, ye pehle se hi aisa hai. This is very common. So this is not a thing. But suppose you say that this hair change is a sign of a protein malnutrition, what other signs you see in the hair?
Easy pluckability.
Easy pluckability. Sparse hair. He has none of that. So you always know that, this is a color that he is born with, and that's about that. Yes? Would you now palpate his abdomen and see what that is? On general examination, any other points?
So nothing.
No other positive finding. So no lymph nodes, bones and joints are normal, so there is nothing else. No skin rash.
No rash.
General Anand made an important point that in the same discussion of malnutrition, look at the parental build also. So now the father is also of a small build. So, keep all that in mind while analyzing anthropometry.
First, the inspection of abdomen. Just inspect and tell us what you want to say.
The abdomen appears to be distended. The umbilicus is everted, and above the umbilicus, the distension appears to be more as compared. The umbilicus is pushed down and everted. There are no obvious scars or sinuses, no dilated veins seen.
So what's your interpretation of what you said? Before even if you palpate.
The interpretation is that there is an organomegaly, most likely a hepatomegaly, possibly a splenomegaly.
I think Khare sir is making a point. If you would have been better off calling this a full abdomen rather than a actual distension. I mean, it's not like broad, majorly distended, but given his general build, it looks little fuller than normal. So, which is obviously important.
On palpation, there is a 3 centimeter firm hepatomegaly. The borders are the margins are well felt. It's non-tender. The surface is smooth, and the left lobe of the liver can also be palpated. I could also palpate a spleen.
What one more finding of the liver?
It's approximately 6. The span is approximately 6 centimeter. It's an enlarged. For a 4-year-old child, it's normal, probably.
Dullness is coming from here.
You
It's around
percussed
10.
only for the upper border of the liver, right? What else should you have done?
Tidal perk.
Yes, that's very important. In the exam, don't forget to do that. Make him take a deep breath, hold it, and then demonstrate that there is a resonant note again.
There is also a spleen which is palpable, a 1 centimeter spleen. There is no free fluid which is present in the. There is no free fluid which is present in the abdomen on percussion.
Any other positive findings?
So just that the liver size I felt slightly more and the span also slightly more. And even the spleen size.
So tell us the sizes, no? Slightly means what?
Sir, liver of 3.5 centimeters and a spleen of 2.5 centimeters. A span of 7 centimeters.
But that would go with her statement, no? Approximately. 6 to 7 is okay, no?
3 to 3.5.
5 is also okay. Why are you being so strict with her?
Spleen size was 2.5 centimeters.
Yeah, I agree that the spleen is 2.5 centimeters, but in liver, sir has always taught us when your size is borderline, you're not sure, then what is the point which will decide whether it's abnormal or normal?
The border and the consistency.
Span and consistency. This is a soft liver, so this is not abnormal only.
Left
Right?
lobe is also palpable, which is abnormal.
How
See,
much is it palpable?
yeah.
Left lobe is never palpable?
Sir, my dear, sir,
Left lobe is not, unless it is much more than right. Left lobe is little big. Left lobe is here, so it would correspond to about 4 to 5 centimeters. About 4 centimeters of hepatomegaly. Right lobe 4 centimeters, might be even little more in mid inspiration. Left lobe is 5 centimeters, permission consistency. And as you said, 2.5 centimeters spleen. Even bigger than that, 3 centimeters, 3.5. So significant hepatosplenomegaly.
Any other findings?
I could find shifting dullness when flying fullness on inspection.
Okay. I think when she was percussing, we didn't think that there was any shifting dullness. Anyway, anything else?
No.
Okay. So now, would you try to tell us what our findings have added to what we discussed on history, or then you take over?
We have a we don't have a malnutrition. We have a child who is short statured. I haven't checked for lymph nodes or oral ulceration.
He said there are no lymph nodes and there are no oral.
And hepatosplenomegaly was expected. So it does go in favor of an immune condition that we were thinking of on history.
Examination is normal. Joint examination is normal.
Yeah, joint examination is normal.
Fine, come. What would you say? What is your final analysis?
I think it's a portal hypertension. You have a liver, you have a spleen, and you have a bleeding. What more do you want? It's typically a portal hypertension. The liver is not large because it's getting shrunken. Okay. Another 6 months it will go down further and the child will develop ascites. My diagnosis is a portal hypertension. Liver, spleen, bleeding. What more do you want?
Sir, we can get any detail about the joint pain. How was the involvement? How was the progress of the joint pain?
We discussed all that. No, we don't have.
Joints are normal now.
It was never significant.
Okay. Joints are normal now. There were never arthritis, some arthralgia, which we discussed. But just now the only findings is short stature, so chronic. Okay. Hepatosplenomegaly and bleeding. Chronic liver disease with portal hypertension.
Sir, in this case, child must be if there is a hepatosplenomegaly and portal hypertension.
Right, splenomegaly is portal hypertension. Bleeding adds to that. Liver is there. The chronicity, short stature.
Child will be in the liver failure, sir, then. Because of portal hypertension with splenomegaly will suggest of the liver cell failure. So,
there is no liver cell failure. Liver is still well. Compensated liver disease with portal hypertension. There is no liver cell failure.
Sir, important signs of portal hypertension like ascites, edema, there is
no. Ascites is not a sign of portal hypertension. Ascites is the sign of a liver cell failure. Okay, so this child has typically a portal hypertension. Findings suggest portal hypertension. Okay, short stature, so chronic illness, liver, spleen and bleeding. What more do you want? Instead of hematemesis, he is throwing blood from below. Okay. What is wrong if I call it portal hypertension? You are from KEM, no? Pune. Yeah, so portal hypertension you must stop.
The 20 days fever in this case.
It's an intercurrent illness.
And I think the fever is due to any cell destruction. Even a cirrhosis can run fever. So fever I am not greatly worried. Fever is any cell destruction. But otherwise it's typically a portal hypertension.
So the consistency of spleen should be soft and
consistency of liver and spleen should not be soft.
Well, she said it is firm. I won't believe him.
Tender hepatomegaly. Tender.
Why should it be tender? Cirrhosis portal hypertension is not tender.
Upper GI bleeding is more common. Should present with hematemesis.
And here it is presented with less common. So that does not take me away from that. I agree with you. Okay, but give me some more reasons why it is not a portal hypertension.
What is the behavior of a child with chronic liver disease? Tell sir.
Portal hypertension. The child won't be that sick. Child is not that sick to have portal hypertension.
Portal hypertension children are not sick.
No, are you talking about isolated portal hypertension or are you talking about a chronic liver disease with portal hypertension? They are two different things altogether. So if you are talking about isolated portal hypertension, it fits in perfectly. It's playing around.
Isolated hepatic obstruction, extrahepatic portal vein obstruction will not have hepatomegaly. They'll have more bigger spleen, and as we see, more hematemesis is more common complication.
So in portal hypertension, what bleeds?
They need not have very big spleen. In fact, you see a 3-4-year-old child with 2.5 centimeters, 2 centimeters splenomegaly and suddenly has hematemesis.
And he has bled, no?
Yes, not.
All that splenic blood has already come out. Spleen has gone small.
It's not a huge spleen.
No.
No.
There are no dilated veins or vessels which are visible anywhere.
So what does it mean?
So no portal hypertension.
Yeah, means in a child who has liver cirrhosis with portal hypertension, you will see all other veins. Only if there is an extrahepatic obstruction, portal hypertension with an isolated vein that is blocked or as a result of arteriovenous malformation, you won't get other veins. But if a child has bled due to portal hypertension, you would have dilated veins on the abdomen with little more distension of abdomen. It's not just one vein has got dilated and tortuous and bled. There will be other veins because there is a generalized portal hypertension there. So I agree with you that this is.
I think all that you would have said is that there is no clinical.
The autoimmune hepatitis as a part of IBD, what we were discussing, you could still explain them.
Sir, there is a comment from one of the viewers that how can you talk about chronic liver disease without jaundice ever being there?
We can
so
still...
your comments on that.
Chronic liver disease may not have jaundice. The point I was making is, when there is a liver enlargement, first tell me whether it's a hepatocyte disease, or is it a venous obstruction, or is it a biliary tract disease, or it is a reticuloendothelial hyperplasia. If it's a hepatocyte disease, this child would be chronically malnourished. We said he is not. If he is so stunted, he would have been malnourished. He would have had edema of feet. Of course, what is hepatocyte? Edema of feet. So he has no hepatocyte disease. And portal hypertension, due to therefore sinusoidal obstruction, is out. Sinusoidal obstruction is the hepatocyte disease. And this child has no hepatocyte disease. So that is out. Could it be a pre-sinusoidal obstruction? If that is so, then the liver is usually big and the spleen is big and the liver is normal. So this is not pre-sinusoidal. Is it post-sinusoidal obstruction? There would be a large liver and ascites. So even that is not there. So this is no portal hypertension at all. That much we knew. You would have said that this child has probably a reticuloendothelial cell hyperplasia. And the cause must be there for a chronic inflammation, a chronic infection. So we come back on the same thing. But ultimately looked like that the liver looked to be near normal. Even the span did not fit in too much of abnormality. And therefore, probably this liver can be taken as normal. A spleen certainly is abnormal. Question is this spleen related to fever? Is it a malaria that he has had earlier and therefore a spleen? So I think on examination, we could say what it is not, rather than what it is. What it is very difficult to make out. Okay. So all that I would say is that if I just go by no history, but just I'm shown this liver, spleen and this child, then I would say that he is not a chronically sick child, because he otherwise looks okay. We said wait for it is not much terrain. He doesn't have significant pallor. So therefore he doesn't have a primary hematological disorder. He doesn't look sick, so he doesn't have much of a persistent inflammatory disorder or a malignancy disorder. So I must almost look at this and say, if he has fever for a long time, if that is the history, and if he has just some liver, some spleen coming up, I would really start wondering whether he has some disseminated infection I'm talking about. And we said earlier that one of the causes of long-term fever is even a tuberculosis. Okay, that history of joint coming up somewhere and a bleeding coming up somewhere doesn't fit in that. In which case you may be forced to say, at the end of all that, we will have to split up the whole story. We will have to say, bleeding is a different issue. Now I take the recourse of what he said. It's a painless bleeding. Oh, so it has nothing to do with his fever. And therefore I split his fever and I split his bleeding. And his bleeding is something else which came coincidentally. Last time it came, this time it hasn't come so far. So we'll be forced to do that. In an examination like this, examiner is not expecting a diagnosis. I'm nearly sure after investigation also they don't have a diagnosis. Okay, we should anticipate what it is. So anticipate he has no diagnosis. He will say, I've done some tests and I don't know what it is. But we will argue out. And when you have no diagnosis, you could imagine what it is certainly not. And sometimes you may have to split the two symptoms and say, fever is something else and this. I think I would almost go to that extent now. You said you had a koilonectomy or something, or you said no? There is.
So the foot nails.
Will that explain iron deficiency in spleen and liver and all?
Can it be sickle cell with crisis? Hepatosplenomegaly, pallor, requiring blood transfusion, fever, pains.
Blood transfusion was because of bleeding.
We don't know. He could have been pale, and small bleeding may have precipitated.
No small bleeding. He bled for 5 days. That's why.
Actually, amount of bleeding he has not specified. On an already
you said
anemic
that there was
child.
loose motions with blood 4 to 5 per day for 4 to 5 days. I think that is significant. This was not a small amount of blood that he lost.
What kind of sickle cell crisis were you talking of?
Painful crisis.
Where's the pain?
Actually, joint pain he had.
No. Sickle cell crisis will not cause all joint pains. It will cause, if at all, pain at one place in the skeletal system, right? And any other abdominal crisis would again cause severe abdominal pain. So pain was almost not there. We had to dig for pain, and then also we didn't.
It would be the chief complaint.
Yeah. Tell us what are your findings, or
so from the history and physical examination, a 4-year-old child presenting with fever, arthralgia, with a history of loose stools with blood, and on examination with hepatosplenomegaly with anemia, in a undernourished status, to rule out any chronic infection, probably chronic malaria, enteric or COX, connective tissue disorders, or inflammatory bowel disease, and to also keep malignancy and hematological causes in mind.
I think we can at least reduce chronic enteric from this. Okay, what investigations have you done? What is chronic enteric? It's news to me. So you tell me. You tell me what. So there's nothing like chronic enteric that I know of, and untreated or partially treated enteric, why you think is possible, then we'll discuss why it's unlikely. So forget this child. Now what kind of a story do you want in enteric fever classically?
A fever for more than 8 days.
What kind of fever?
High grade.
So first point that is missing, there is no high grade fever. Then what more about the fever? Step ladder pattern, so rising or worsening trend of fever. That's also not there. Then
Symptoms like abdominal pains, vomiting, sick child.
Sick child, that's also not there. Then now further, even if this child was, let's say, treated with an antibiotic on day 1 of his illness, which was partially working on an enteric, as you go along, what findings will you get in enteric? So what is more, hepatomegaly or splenomegaly? Hepatomegaly is more obvious and the first finding to come up. Here we are debating whether the liver is abnormal or normal. We are not sure. Whereas the spleen is definite, it's very firm, seems to be chronic. Okay? And what else? That bleeding obviously can't fit in. Those joint pains from day 1 can't fit in. So lots of points against calling it a partially responded enteric. What investigations have we done?
So during the first admission, when he had come with loose stools with bleeding, the hemoglobin was 2.2. The total count was 10,300 with a poly of 46 and lymphocytes of 32. Platelets were 1,37,000 adequate on peripheral smear with a hematocrit of 7.4. The child was transfused on that. The hemoglobin was
Speak
built up.
louder.
The hemoglobin was built
mic close here.
The hemoglobin was built up with a PRC transfusion, and then the child was discharged. And on this admission, he had come in with an initial hemoglobin of 9.7. The total counts were 4,500 and platelets were 51,000. And the most recent complete blood count is with a hemoglobin of 5.5, a total count of 3,900 and a platelet of 1,28,000 with a hematocrit of 16.7. The MCV was 79.5, MCH was 26.4 and MCHC was 32.9 with an RDW of 49.3. The blood culture was negative, the urine culture was negative, a urine routine was also normal, enteric workup was negative. Dengue NS1 and malarial antigen tests were negative. The liver function test, bilirubin was 0.5 with a total protein of 6.2 and albumin of 3.8. Blood urea nitrogen of 9 and a creat of 0.6 and calcium was 8.8. The prothrombin time was 14.7 with an INR of 1.31.
So you said the hemoglobin dropped from 9 point something to 5.5.
5.5. Over the past 12 days.
Stool routine for occult blood? Stool routine for occult blood?
Sir, it was done last time. It was having, when he had come with the bleeding PR, at that time 25 to 30 RBCs.
No,
and
is it important now with this drop? You're losing blood somewhere, no?
Yes, sir.
And the picture is of an iron deficiency. So what's causing that? You need to find the source. So instead of BUN, creatinine, calcium, I would have done a stool routine.
I think if you have a drop of 4 grams of hemoglobin in a short time, you need an answer to that. Only sometimes the problems are that when a child is admitted, if the child has not been feeding well, he is a bit dehydrated, a little hemoconcentration gives you a little more hemoglobin. By the time you hydrate him, that comes down a little. By then you have done many tests, you have bled him maybe. So we will have to look at very carefully whether is this a significant drop from the pathology point of view. If it's a significant drop in a short time, then there are only 2 issues. One is bleeding, okay, or he has hemolysis. He has no hemolysis, he has no jaundice, and therefore is bleeding. So could he be bleeding an occult bleeding? It is yet to come out of the rectum, and he is probably bleeding intestinally. What he did earlier, he is now doing it occult. Okay. How would you have made out clinically? Now his hemoglobin has gone down, and my consideration is he has an intestinal occult bleed. Could you make out clinically whether he has an occult bleed significant to bring down hemoglobin? But it has not come out, it has been retained in the intestine. After all, several feet of intestine can retain a lot of blood before it comes out.
easy fatigability over the past, in the course
So
of
your
the
answer would be, I would have done a
anemia.
pulse rate. Okay. His pulse would have gone faster. Okay. What I mean is that we need to be careful about all that. And if he has dropped down so much, then could an aplasia do that? Unlikely. Could a hemolysis do that? Yes, but not in this child. So he has to be bleeding. If he has to be bleeding suddenly, I think his pulse rate would have told me that why is it suddenly gone up, which means he has an occult bleed. If he has an occult bleed, I go back and said, last time also you bled a lot, this time you are about to bleed a lot. So again I start looking at whether it's some ulcer bleeding, is it an inflammatory bowel, but the story did not look like that on examination. So again we are not very sure. And what we anticipated was that his routine investigation would not show us anything. Okay, and it did not. Okay. Now what next?
Could it be systemic onset of JRA?
There was no rash. We were suspecting that. Even after digging into the history, there was no evanescent rash. And without the rash.
And there are many things in the history, as we said, does not fit in that. Okay, nor the counts fit in, etc. He should have had a leukocytosis, he should have a thrombocytosis, etc. So very unlikely, and there is no reason why a systemic.
See, usually systemic JIA comes with higher fever, and as sir already mentioned, very high spikes, 2 spikes per day. In between, the child may look normal. Rash is not the main thing to go by, but typically they would first come as PUO, means only fever and nothing else. But once joint manifestations start, then the joint manifestations would persist. So that is the funny thing here. Not high fever, joint manifestations only in the form of arthralgia, and they have gone also. That is very unlike.
Sir, as you said, he is bleeding only. Such a loss of fall of hemoglobin has to be hemorrhage or hemolysis. No hemolysis, so bleeding. Bleeding is not obvious. Can we go back to he will be bleeding from upper GI tract? He has a spleen. If you consider a normal liver, is it still extrahepatic portal hypertension? Only thing is, with a massive bleed, he should have more of hematemesis and not melena. I have not seen somebody only coming with melena. They will come with hematemesis. That was the only thing, because there has to be a significant, sir, drop is significant from 9 to 4 in a matter of 10-12 days.
Sir, again the points.
And small amount of blood, occult blood 2 plus 3 plus is not adequate to explain such a big drop.
Correct, sir. So such a big drop, one, the clinical condition of the child should deteriorate for such a big drop. I mean, 9 to 5 is like half, so he has become half. So that clinical condition doesn't reflect. And for that bigger bleed, it will not come as hematemesis. So what upper GI bleed can be hidden will be a small bleed, and the varices won't bleed that way. They would bleed like a one big bleed kind of a thing.
Or something other related vascular malformation, which we don't see, why did it not bleed for last 4 years, we don't know. But it has bled now. It has bled obviously once, and it is hidden now. So may not be very low down in the colon, little higher up. And then arthralgia and all those things just... So coming back to explanation of fever again, we are, sir, nonplussed, and sir's approach is worth remembering. When you have a hepatomegaly, it is hepatocyte disease. Obstruction means portal hypertension, pre-sinusoidal, sinusoidal, post-sinusoidal, and reticuloendothelial involvement. And therefore then we may almost have to boil down to reticuloendothelial disease as a cause of splenohepatomegaly. And therefore we have to go back to infections again, whether tubercle, malaria, any of those things. Though it doesn't explain the bleeding.
Is it a storage disorder? Okay. The bone marrow is getting storage. You have a thrombocytopenia. You have an anemia. Okay. You have a spleen. Okay. He is coming out with a gauches. Wait for some more time. He will have a bigger spleen. He is already short stature. So he has got a storage disorder.
It could have manifested in earlier stage, like at 1 year, 2 year, not at the age of 4 years. So it is unlikely to consider for storage.
I just want to bring a point that a storage disorder to begin with would just have even just a spleen and nothing more. Wait for some more months or years, a spleen would start getting enlarged. This child has got already a disseminated storage disease, if it is a storage, or that these signs don't go back. Because it's already affecting the bone marrow, it's already affecting his stature, it's already affecting his spleen, liver, then that is not fitting in. So this is not a disseminated storage, but yes, a storage could just fool you with a spleen there, etc. So I don't think we have a diagnosis in this child. We fail to understand even after tests. Who will tell me now what next you want to do? Liver biopsy? We haven't done imaging as yet. Yeah, could we do CT scan? Could we do a liver biopsy? We have to do something more.
Before liver biopsy, UHG abdomen we can see.
UHG abdomen is done, mild hepatomegaly and minimal interloop ascites.
Pardon?
Mild hepatomegaly and minimal interloop ascites. Echo texture is normal.
Minimal interloop ascites.
Which means normal. Yeah. So this is over. Now what next? So if you are a pediatrician now, what are you going to tell the parents that what else do you want to do? That's the question.
I would like to go for the colonoscopy to rule out the source of bleeding.
That's a good suggestion. Okay, he's bleeding, no? Let's look at where he's bleeding from.
Barium, you look at the upper end, look at the lower end also. And while we do all that, we may treat also him for possible malaria or something. On one hand, we start giving him anti-malarials on one hand. If his fever disappears, we are happy. And of course, GI endoscopy, upper and lower, would be in order.
Has HIV been done?
So HIV is sent today.
Not.
It's awaited.
I think all that I wanted you to say is that I would say that at this time I would just treat his iron deficiency anemia. Okay, I would build up his nutrition. I would wait and watch to decide what more I want to do. As we already said, fever seems to be different, bleeding seems to be different. The endoscopy is a good idea because we want to see if he's bleeding, if there's a polyp there, etc. So that's quite all right. Liver biopsy has no role at all. We have been saying there is no primary hepatocyte disease, so no liver biopsy, no CT scans, and therefore at this point of time just wait and watch. I think that is how it would be true. See, this case taught us how we could have sometimes to split two symptoms of two different etiologies. Looks like that they were two different, but we tried to make it into one disease and we could not fit in happily. Then when we examined, we still said none of those exist, and now we are faced with saying that his fever could be, like Dr. Kari said, why not give chloroquine and just hope that his fever gets better, etc. I feel that is where we stand just now, yes?
How have you treated him?
Yeah, one sec, Rajesh.
Sorry.
There was a query. Listen to me, Rajesh.
Yeah, sorry.
There was a query whether this could be hemophagocytosis. Well, those children would be extremely sick. So that rules it out completely. And more tests are asked for. Have you done a CRP, ESR and a bone marrow?
Yeah.
Dr. Amrit, have you done?
Not yet, sir.
Good.
I think one of our Wardia students must answer whether it's an HLH. We have an immunologist with us. Okay, she's already a DNB, but she must have seen, 97 HLH? Yes, if I know rightly. So tell us whether this could be HLH. Yes.
She's waiting for the 98
So I think it's unlikely. The child, as sir said, should be more sick than expected, and so only just going by counts and a hepatosplenomegaly to say it's an HLH would not be correct. We should first look if we can find out some other cause, then jumping to HLH.
So just a bicytopenia or pancytopenia doesn't make it an HLH. Clinical story doesn't make it that. I think we stop on this case at this point of time. Sorry.
So I wanted to ask you, you had asked us actually, can the liver and spleen be explained by iron deficiency anemia? So can it?
No, the point is that generally when you have a spleen, you don't talk of iron deficiency anemia, though rarely even splenomegaly is known in iron deficiency anemia. But which means that iron deficiency anemia mainly do not have liver and spleen. But yes, one would have seen a just palpable spleen and an iron deficiency. You don't know whether that was old malaria doing it, and you happen to see iron deficiency. So as a rule, deficiency anemias have no hepatosplenomegaly. That's a rule. Exceptions, yes. So that is where we stand.
And sir,
Just like a Kala Azar it could be.
The only thing is that Kala Azar is a chronic progressive illness with pallor in significance, a large splenomegaly, and a gradually malnourishing child.
Fever won't have
not a non-sick child.
The adjective for Kala-Azar is catabolic. That child will be wasted. Remember that.
The answer to that CBC, ESR and bone marrow. CRP, ESR. You want to give reasons why you don't want these tests?
We would like to perform these tests.
You would like to perform. Okay, why? Tell us what CRP will tell you, what ESR will tell you.
So both of them will point towards any chronic inflammation and connective tissue disorders. If we are thinking of, then both of these should help, and the bone marrow will help us rule out if there is any hypersplenism, because there is a pancytopenia as of now. Probably that will, and HLH.
Where is the pancytopenia? Your WBC counts are normal, no?
3,200 and platelet count of 1 lakh and an HB of around 6.
So platelet count was 51,000.
Never.
And it has become 1 lakh.
No, it is dropping. It is
Dropping means what? 20,000 here and there is not drop. Yeah.
It had come to 50,000.
1 lakh 50,000.
But it has come up again.
20,000.
एकदा 50,000 होता.
मागच्या वेळी ब्लिडिंगच्या टाइम.
Was it ever 50,000?
Yeah, it was 55,000 once when he had come initially the last time. That could have been due to the acute bleed.
I think all that you would have said is that undiagnosed pancytopenia in a sick child, you would certainly do a bone marrow. And undiagnosed pancytopenia in an otherwise normal looking child, you would wait and watch to decide whether you want to do bone marrow. There is no hurry to do that. Okay, I'm sure that my hematologist told me the other day that 5th bone marrow picked up a leukemia. I only told him next time you do the 5th one first, because that's the only way. To me, 5th I'm not going to wait till diagnosing. Yes, there would be patients where it evolves and few bone marrows are normal, the last one picks it up. Yes, but we are not going to wait for that at all. So I think that's where we should end up. I think what we are going to do today also is a counseling session. Okay, one of our hemiplegic who was to be presented got so well quickly that he could run away. So I suppose we will have some counseling session. We want some volunteers. Okay, Anand, will you do that? He will do it.
I will
He's the
contribute.
boss. He will not. Yeah. Come, who will come? It's not difficult, isn't it? We all counsel. Okay, come. Come, somebody who wants to pass exam. That's what Anand says. Those who want to pass DNB, please come forward. Nobody wants to pass. What is wrong? Yeah. Come, somebody.
No, you can attend these clinics after passing the exams also. Amol is an example. So you you like this clinic, so you want to keep coming. You can come after passing.
Come on, somebody quickly. I think we will do one counseling session for next 15 minutes before we break. Come, who will come?
Come on, this is an excellent learning experience. What is there in counseling?
One of you come. And one of you come from this side. Come. Let's be fair to both the parties. Who wants to come?
The rightist and the leftist.
Yeah, leftist and rightist, yes.
Come, very good, come.
Come. Anyone? Come on, some boys now, one of you must come.
Come.
Every time these girls are coming and talking. Yeah, come.
Chal.
Come on.
Nothing, yeah, come.
Doesn't matter. I think this is the place to make mistakes. Yeah. Once you have finished making all mistakes, you have nothing to make another mistake in the exam hall. You should have done already one of them. So I think that's the way it should be. Come.
Come, you stand together. Yeah. So we'll give you a scenario. Sorry. So you are seeing a 1-month-old infant who has been brought to you with high fever with no findings on examination. Okay? What do you think you should do?
Ask the detail.
Okay, or let me jump that. So you want to admit this child for investigations and further management. So you have to counsel the parents that you need to admit this infant.
Rajesh,
What is happening is that,
including lumbar puncture.
Yeah, this 1-month-old baby has come to you with high fever. You have found nothing. You told the parents you are concerned and you want to hospitalize the child and even do some tests including a lumbar puncture. The parents say, why? The child is so looking all right. Just for 1 day of fever, we can't do all that. Now counsel the parents that this is very important and they have to do it. So any one of you start, then the other one can pick up. So you counsel me and say, no, you have to admit.
Good evening. I am the treating doctor for your child. In which language are you comfortable?
Any language, because I am upset with you. You are hospitalizing my child. Yeah, you are talking English. Yeah.
Your child is having high-grade fever and child's age is 1 month old. So the high-grade fever, this is the Since how much days child is having fever?
Very high fever.
1 day.
24 hours.
24 hours. In this age group, this much fever is
Right, you are right. Go ahead.
So first think in your own mind why you want to admit this child. What is your fear? And convey the message to the parent. That's what you are doing, no? Yes. So what is the reason you want to admit and do all the tests?
You want to add pitch-in, help her?
In this age group, the progress of the fever would be many a time would be very fast. So it can be a child is well now, but it can be a progression of the disease process can be a fast, and many a time the fever will not be localized. So though child is looking well, but there can be a hidden infection maybe there inside. So we have to rule out the sepsis part.
But doctor, many times it's a common viral infection, no? I will just take some paracetamol and will be alright.
This is true for the older one.
So you think the younger ones don't get viral infections?
No, younger one can also get, but in such situation they can't fight with infections and they can become ill very early. So we have to observe them. At least for observation also we have to admit.
And what are you going to observe?
So, how is the fever pattern and how
that I can tell you from home also.
All the things that how is the breastfeeding, how is the feeding
No,
of the child?
I will tell you, no, is breastfeeding all right?
Those are all sepsis workup. To rule out the sepsis, we have to admit the child and we have to.
I can do the test. I can do the test from outside. No, why do you have to admit? And why do you want to do the test? What test are you doing? You don't know the diagnosis. No, what test are you doing?
To come to the diagnosis, we have to.
No, but what test? From head to toe, you will test my child. You said you don't know the diagnosis. What are you testing?
To establishing the diagnosis, we have to.
So what test do you want to do? You said even a lumbar puncture. I have not heard anybody doing that for 1 day fever.
In this age group, as the child is immunocompromised and
no, he is not immunocompromised. You told me at birth he is a very normal child and I have been breastfeeding.
Not immunocompromised exactly, but child is the immunity will not be as good as the.
But you gave me 3 vaccines at birth saying that he has got good immunity. He can take 3 vaccines. You gave me why all 3? He said no, you have got a good immunity.
Child can't localize infection in such situation less than 1 year age group, 1 month age group. So we have to find out the infection where it is. For that we have to do all these investigations. If we don't find that infection, so it can spread anywhere. The widespread infection can occur and sepsis can occur to the child.
Just do blood tests, no? Why lumbar puncture?
Does anybody else want to help? See, it's not only for them. Everyone is.
Sir, as infection is very common in this age group, we can admit this patient and investigate by step manner. Though lumbar puncture is in our mind, but we won't do right now. We will do other tests first, and based on that test result come, we will start our treatment. And we just want to admit not for the observation purpose, but because of pneumonia, septicemia and meningitis infection are very common in this age group. See, we want to know the progress of disease. In such a case, like if you, because sometimes convulsion and that kind of movement we cannot picked up by the even parents, we picked up by the doctor because it's very atypical presentation. So thus we want to look out whether the child is a movement of, convulsion movement, and is there any other abnormal activity. So that's, we want to just convince that we assure you that we just admit this patient, observe the behavior, the fever pattern, investigate in the stepwise manner, and based on that investigation we will go forward and we'll start the treatment.
I don't mind blood test, but instead of lumbar puncture, why don't you do a CT scan of the brain? That is better. I don't want the lumbar puncture.
Yeah, I understand your concern. I mean, the pricking child is...
Whether the brain is normal or not.
Yes.
Why don't you do CT scan? I am told that is harmless.
I understand your concern, but CT scan has also radiation chances. Okay, and CT scan is is not an invasive procedure. We investigate patient from outside, but invading, like dealing with the fluid from your dealing with the fluid from your son or daughter, we can directly find out whether which type of infection, bacterial infection, viral infection, if there is infection.
You said pneumonia you will pick up by X-ray.
Yes, sir.
Lung infection is picked up by X-ray. Why don't you pick up
in early
brain infection by CT scan?
Early phase of infection of the brain, like meningitis, will not be picked up by the CT scan. It will take a time. And
Doctor, you give me antibiotics. No, I don't want lumbar puncture.
Yeah, but to give an antibiotic for the duration of the treatment also, that lumbar puncture and CSF examination is the most.
I understand. I mean,
but the duration of the antibiotic and
for a long time if you want.
But the causes of brain infection are not only bacterial. There are other causes of infection, other causes of CNS infection like viral or parasitic or other infection. Even if we give antibiotic, if there is other cause of viral or other cause of fungal infection suppose, and if we give antibiotic, then patient will not be getting better. So that's why we have to investigate thoroughly. But right now lumbar puncture is not the issue. First we want to rule out the basic investigation. We want to do the basic investigation, and if basic investigation click something, then we won't do the lumbar puncture at all. So,
but for the duration of antibiotics also, we have to do lumbar puncture before that.
Because
if there is infection and we are not doing lumbar puncture and we are giving antibiotics, child can improve, but the duration we will give, that will be less. In case of meningitis, we require longer duration of antibiotics. So we can't decide that.
Suppose your CSF report is normal, then you would have unnecessarily done the test.
But sir, lumbar puncture is a must in this age group of the child. Because
if it is normal, then I would say you have done unnecessarily a test on my child.
But if we would have not done the lumbar puncture, then if there is a high chance of to partially treat if there is a disease.
So there is I want to set up an example, half glass full. If you see the empty part, then it's a negativity. If you see the full part, there is a positivity. What if we pick up the positivity? What if we pick up the infection? Then it definitely going to help.
I think you have 8 minutes normally, and you will be required to counsel completely in 8 minutes. Okay.
Better mind, give that mic to sir.
So what would you have said? Look, I am Dr. Ambekar, I have seen your child. Your child looks quite alright just now. But as a 1-month-old child runs in high fever, there is almost always this to be a bacterial infection and not other kinds of infection. Other kinds of infection at this age are extremely rare. So we know that this is going to be a bacterial infection. Bacterial infections can occur in this child just with fever, and other symptoms may follow later, but I want to pick up as early as possible so that I can completely cure. It could be in the chest. I can make out by a simple chest x-ray, which I am going to do. I am going to do a simple blood count, which may tell me whether there is a significant infection or not. I am going to check your urine also, because that's another place where you have an infection. And if these reports suggest there is an infection, but it is not in the urine and it is not in the chest, then I certainly want to look at whether it is developing in the brain. What happens is that when the germs come in the body, the first reaction is fever, and then germs settle in one of the organs, and only then the next symptoms come. I want to pick up that disease as early as possible so that he is completely cured. So once if I have ruled out a pneumonia and a urine infection, I am sure I am going to do a lumbar puncture. It's a very safe procedure. It will have no side effects to your child. We will see that we will do it without causing much pain or discomfort. Your child would absolutely be alright. But I would definitely know whether there is an infection or not. If we pick up an infection at this early stage, I am very sure that your child will have no damage to the brain at all. But if we are late, then there could be a damage, and there could be a permanent damage also. So the risk is so high that you are not going to accept that risk at all, and even if the CSF turns out to be normal, you should be happy that there is no infection in the brain, but I need to be very sure to do that. So don't get worried. I'm going to do it only if I have ruled out other infections, and I will do it without causing any problem to your child. Your child will not be crying, your child will not have any anesthesia, you will be able to breastfeed immediately again. In the next half an hour we'll get the report, then I'll come back to you and tell you whether it is meningitis. If it is meningitis, at this stage he is going to be absolutely cured. He will need some antibiotics. He will need antibiotics for a longer time. And if it is not there, then we know that he may just get well without our doing anything. So I understand your worry. Please allow us to do a CSF. If you insist on not doing a CSF, we cannot give antibiotics to a child because we don't know which antibiotic to give, we don't know what dose to give, we don't know how long to give. And if this child gets well in 2 days, we don't know when to stop. If we haphazardly treat the child, you will be much more in danger of a permanent damage, and therefore it's much better to do that. We also don't like to do a lumbar puncture just like that, but here is a situation where we want to do it, and I'm sure that you will be happy at the end of all that. So please understand and accept that we will do it. We are doing it only because it is most important. Right? Good.
2-3 small other additions, or means addition in just remember. See, one is whenever you are counseling, try to use minimum medical terminology. Because here we are rehearsing and we are doctors, so involuntarily when you talk of anything, try to use minimum medical terminology. Try to talk in as much lay language as possible. Secondly, your tone of counseling. So if I may just say for learning purpose, I think his tone was the best. Your tone was a bit strict. So your tone should be this. And of course we didn't specify very clearly maybe, but don't change the condition that you have been asked to counsel. For example, if we said ki you have to admit and counseling ki you need admission, or if we said you have to do a LP, then don't bargain and say okay we will not do a LP. If you have been told that you have to convince for a LP, then you have to convince for a LP. Then don't say that okay we'll do this test, that test, and if it doesn't come then we'll do. See what you have been asked to do and follow that perfectly.
I think just one more point is that you practice counseling, fluency is required. You don't have to wait, think, again talk, no, same flow. I'm sure here you are a little under stress, but there you will be more under stress. So you practice, and I think just take it easily as you will talk to each other. So fluency would make that, and a confidence. Okay, no shaky thing. So I am sure over time we'll practice more often and it will go that. Is that?
Anand asked you exactly that what were the reasons, forget this counseling session now. Suppose you have such a baby, why do you admit? For these reasons only, no? So you have to just spell out those reasons in words, what you had in mind. Okay?
I think we are lucky today to boost your confidence. The last batch which always attended here, that talked a lot, participated, fought with each other, learned so much, and therefore also passed. I imagine 80-85% of you passed. Yeah, wonderful. Failing becomes difficult when such batches come and talk and practice. Please come forward. Please, all of you who have come here specially to meet all of us, please come. Please come. I think let us hear from them the reason of success. Okay. Don't take it seriously if they said, oh, we came here, we learned from you, so we passed. Don't take it seriously, we are not going to do that. Okay, but there must be something else which I thought they should share with you. Please. There have been many others, some of them have been from out of Bombay. Okay, some are not here now. But imagine 80-85% passed. It gives us a tremendous happiness that whatever little we do seems to be working, and we are all happy. And we are happy that you made us happy. So that's wonderful. Please have a word with these people. Whatever you want to say, tell us what made you pass. Okay, so that these people know they will do the same.
I think the most important thing which helped me was the letting go of the fear to talk and being able to answer questions in the clinic whenever asked or whenever we used to present cases, and to practice amongst ourselves all the counseling sessions, history taking, and just getting into the practice of taking cases in that stipulated time that is allotted to us, 40 minutes, finishing everything as we do in the exams, and presenting to each other how we would present to an examiner. And practice is, I think, what made us really crack the exam.
Yeah, correctly said. I think participate in the common discussion, presentations and these clinics and amongst yourselves, and taking case presentations will help you more, and your own discussions with your colleagues, and it will improve and boost up your confidence also. So that helped us to clear this exam. So
did you make a group?
Yes.
Did you work as a group?
In Wadia we had a group of near about 40-45 students. So we used to sit there in the library. We used to present the cases to Ambekar sir, even in minority. So it helped a lot, and sir also teaches so well. So we are really thankful to all teachers. I'll just hand over to my colleague.
I think the way Ambekar sir told us when we went to meet him after we completed the exam was that we worked as a group. So we were there in the library from morning to evening. We had discussions. Most of it was how sir compelled us or motivated us to do this, do that, which did make us discuss things, did make us do OSCEs together, and also made us take cases, present to each other. It actually helps if we present to each other, because the other person can make out the faults, you realize where you are not done, and presenting to Ambekar sir helps, because the way you would expect an examiner to ask you, you would realize that this is what is supposed to be answered to a particular question when asked, how it does not fit into this, why does it fit into this, simple things. And Chandelier sir and Chokhani sir, for whatever you all have taken for our statistics, poisoning, whatever OSCEs, whatever things we needed, Ambekar sir organized it for us in Wadia, so we had those sessions along with case presentations. So both OSCEs and cases we could work on as a group together. That really helped.
I think most of them have covered all the points. I don't think there is anything more to add. But yes, I would like to stress that the group studying has a very good effect. It not only motivates you, but it prevents you from going into boredom, reading the same stuff again and again and revising it. So yeah, groups do help a lot.
Do you think that practicing is more important than sitting with your books and reading?
Yes.
Did you fight with each other?
Yes.
Lots?
Lots.
So that's a healthy sign, no?
Very good sign.
I just think that be it any exam, whether it's DNB or even our MD or the DCH exams, whatever that you have worked in the 2 years or 3 years definitely comes to your help in your exams. Whatever cases that you have seen on rounds or in casualty everywhere, because in your exams finally, if it's DNB, you don't tend to get those cases that you've actually prepared for or been always listening to case presentations and attending or going through the books. You just suddenly end up getting a case which has not been there, and whatever comes to your help is what you have worked in the ward, the rounds that you attended, seen in the casualty, and that comes out in the exams finally. So it's not that you never think that your preparation is not enough or whatever. You work for 3 years, 2 years, it comes to your help at that time. That's one. Secondly is that when you go and answer the exam, you always tend to think that I have not prepared enough. And listening to all the stories that like people have answered in second attempt and third attempt, and people fail so often. I think the best thing is to go and think that what is the worst thing that can happen. Worst thing is that I may fail. That's it. You'll answer again. So when you go with the feeling that there's nothing to lose, just go and answer. That's the best attempt that you can give. Just go with the feeling that nothing is there to lose and you answer, because what you go prepared with, finally in the exam, everything is totally different, just the opposite. And group study for DNB definitely utmost importance, because there are so many topics probably that I have not read, but I have only done group study, then I have gone and I have answered, frankly. So that is one thing which is irreplaceable, group study. You discuss, you pull each other's legs, make someone present, and then you act like the worst examiner in the whole world and ask him all sorts of questions, the answers to which you don't know yourself. Really. And that helps. And definitely these classes, science clinics, be it the classes in Vadia with Ambedkar sir, and all the classes have been of very good use to us. So I'm sure like those have to be attended.
All they have said already. So I just to thank sirs, all our sirs, and always make the group study as they told, and always be the confident, make your confident up level, so we'll be happy. And more specifically I will say, do not underestimate the OSCEs. I cleared because of the OSCEs. So do not underestimate the OSCEs, especially observed stations. Make your confident, build your confidence for the observed stations. You will clear definitely if you are cleared in the OSCEs. It's my personal experience.
So, Dr. Pandey, I have to ask you a question. They have said everything and they were repeating themselves. This exam, is the examiner important or you? I mean, you passed because the examiner was nice to you or because you were well prepared? This is an important message which should go to everyone.
So I think
they say, na, wo examiner khadus tha. So what is your take on that?
So I think whoever be the examiner, that is not in my hand. Whatever I can do, that is the best I can. And Ashwin told that we should not, I disagree with him a little bit by thinking what is the worst that can happen. I would rather go in an examination thinking that which is the best thing that can happen.
No,
go with the mental.
Saying that after a DNB exam, no student has been shot or hung or that's what he's saying.
Okay.
We can always come back alive.
Yeah, if that is the worst thing, we are always going to come back alive. But while going to the examination, the best mindset is going to be how I'm going to clear this examination. Right. And like everybody has mentioned, a group study is the best. I don't think if passing this examination is difficult, by studying alone, it is even worse. So you have to form a group, maybe 2 or 3, whatever, depending upon how well you gel on. But group study is very important. And like always sir says that if you want to pass, talk. If we are dumbstruck here, you won't even realize what has struck you there in the exam. So it is better to talk here rather than keep quiet there.
And we remember all of you because you did talk. So we are very happy about that. Well done. Congratulations.
Thank you, sir.
Well, I think you all have boosted up your morale. I am sure in the next 6 months, many of you will be standing here and we will clap. Okay? Thank you very much.
Just a couple of announcements. Sunil, look at me. So the next broadcast is on the 14th of January from Chennai. The subsequent broadcast will fall in the Pedicon week, so it won't be there. And the Delhi broadcast will be in the last week, which we'll announce on the 14th. Thank you so much for joining us. इधर एक भी काटेगा वो भी खाने का नहीं